So before we begin, I would like to share some details about Academically. Headquartered in Australia, Academically is an edtech aimed at helping healthcare professionals excel in their lives and their careers. It was established by Dr. Akram Ahmed, who is an educationist and a healthcare professional with years of experience across several roles in India, Malaysia, and Australia. Academically offers support to healthcare professionals who wish to upskill their careers by migrating to Australia and other countries, setting new standards by providing preparation courses for most advanced global healthcare exams. Academically offers guidance, resources, and unwavering support. On your screen is our founder and CEO, Dr. Akram. Dr. Akram is an esteemed clinical pharmacist, distinguished professor, and accomplished research scientist with an impressive 15 years of teaching and research experience in India, Malaysia, and Australia. With a determination to help healthcare professionals across the globe achieve their dream of moving abroad, he started Academically. Though through his initiative, he provides education and training for pharmacists, medical doctors, dentists, nurses, lab technicians, and physiotherapists for various medical registration exams so that they can move to their dream country. To further support the career advancement of healthcare professionals, he has now launched a study abroad program for those wishing to pursue higher education abroad. Now, I would like to request our academic head, Dr. Rini Sharma, to just take it on from here and just explain about the course.
Thank you, Bharti. A very good morning to all of you. So I'm Dr. Rini Sharma. I'm the academic head for medical courses at Academically. I welcome you all to the webinar. All of you who are in their journey of AMC and some of you who still have to decide. I wish you all the very best, and I hope this webinar helps clear your doubts and you can decide on your future career journeys. Thank you. Good luck once again.
Thank you, Dr. Rini. And on the screen, we have a team of well-qualified faculties who help you once you join the platform. So now today I have with me Dr. Priyanka. Dr. Priyanka herself is a MBBS DGO and AMC qualified faculty who recently got placed in Australia as well. So now I would like to hand it over to Dr. Priyanka. So over to Dr. Priyanka. Let me just unshare my screen and she will take it on from here for a very valuable masterclass.
Hi, everyone. Thank you so much, Bharti, for the introduction. Let me just start the PPT. Is my PPT visible?
Yes, clear.
Okay. All right. Hi, everyone. I'm Dr. Priyanka. I am a gynecologist with over a decade of experience. I am from Mysore, Karnataka. I started my AMC journey with Academically last May, and I did give my exams in November, and I cleared the AMC Part 1 last November. And now I have a job with Western Health, and I am soon to start once my visa gets through. So now I'm a faculty at Academically. So super glad to be here and to be doing this. And today's topic is postpartum hemorrhage. It is one of the most important topics, very, very repeated topic in part 1. And you will also probably get a role playing or a labor room scenario sometimes in part 2 with prioritization, with a labor room prioritization or something like that. So postpartum hemorrhage is, again, a very important topic, even in obstetrics as such. I'm sure everybody who has finished their internship, who has done their obstetrics, gynec part, rotation has probably come across this, and it is no less than a nightmare. It is very important to recognize this and also take measures at the earliest. So let's dive into the topic and let's start. So a stitch in time saves 9. This is a very old English proverb which still holds good, especially in medical field, I think, not only in postpartum hemorrhage, but also a lot of our emergencies, where if we identify something sooner, we are able to take measures and make sure that it does not progress and become really bad, and we are able to save the patient. So very fine line between morbidity and mortality here, especially in postpartum hemorrhage. I've seen patients deteriorate within a matter of minutes in front of me in my experience. So It is very important. And also, not only just in a developing country like India, where it is one of the most common causes of maternal mortality in India, but even in Australia, as we can see, the South Australian guidelines. Just give me a minute here. So yeah, this is picked up from South Australian guidelines, and South Australian guidelines says that postpartum hemorrhage is the second most common leading cause of maternal mortality in Australia, and it is a significant contributor to maternal morbidity as well. So even a developed country, first world country like Australia does have this issue. So it is quite rampant topic for you in AMC Part 1. So RANCOG also says that postpartum hemorrhage remains a major cause of both maternal mortality and morbidity within Australia and New Zealand. Postpartum hemorrhage is common with an incidence in Australia between 5 and 15%. It's not much, but it is something. While the majority of these cases are minor, requiring very little active management and causing minimal morbidity, it must be remembered that it is a leading cause of maternal death both globally and in Australia and New Zealand. As obstetricians, we are left to face the scenario more often than we can imagine. It is called an obstetrician's nightmare. Trust me, it is very, very, very. It is a nightmare even today when I face it, and sometimes it still takes us by surprise. The impact it can have on how fast a patient can deteriorate in the scenario is very exponential. So let me start this by giving you a real case scenario which I have faced in one of the medical colleges that I worked in as a senior resident. And so I did work in a medical college for 3 years, and it is a little bit away from Bangalore. It is a rural medical college. So we have the next blood bank in Hassan that is quite a little bit away. So any kind of emergency like postpartum hemorrhage, we have to be very prepared. So we have to know that there are this many amount of blood products available and all that. And if, for example, we are getting a patient with postpartum hemorrhage or we are delivering a patient that day with high risk, we do have to inform the blood bank, know how much blood is available and all that, because blood is really very important when you actively manage postpartum hemorrhage. So it is a well-equipped hospital with more than 1,000 beds. But like I said, it is a rural place, so the next blood bank is quite away. So unfortunately in India, especially in rural places like that, what happens is the referral system is not very strong. There's not much communication. So when we get a patient referred from a tertiary, from a primary center or a secondary center, where this was the place I worked in was the tertiary center for some peripheries there, and we don't get informed about the patient. We just get the patient when we are on call, and we just have to manage whatever comes in. So that is one issue there. But otherwise, yeah, you should be equipped anyway to handle postpartum hemorrhage. And so one of those days was when I was on call, and we received a patient from a primary center. She had just delivered an hour ago, I guess, and she was actively bleeding. There's active ongoing postpartum hemorrhage. We had no idea about the documentation, what was given earlier. This is another issue where when there's no communication, we don't know what was tried earlier, and we don't know up to what level of whether pharmacological management was tried, or should we just power through and go to the surgical interventions. So clinically, you have to be very good at identifying this. So finally, we received this patient, and turns out that she was hemodynamically not that stable. We quickly took her blood pressure, and her peripherals were kind of cold. Blood pressure was low, and there was tachycardia. So this is something which will tell you that this person is going into a hypovolemic shock. So clinically, you have to be able to identify what stage of PPH a patient is in when you receive a patient or when you are seeing this patient with PPH. So as a team leader there, this is what I did. So I hope this gives you some kind of perspective on management when we get to that stage now. So I told my team, we had a team of interns and postgraduate students and nurses, of course. So I told my team to just start the basic resuscitation. She had an IV cannula already. So we put her on another IV cannula, and we started a fluid resuscitation and kept her warm. Meanwhile, just took a very brief history as to if anybody knew what had happened earlier, saw her records, and as soon as possible, send a person to get the blood. That is very life-saving in postpartum hemorrhage. So I sent a team of interns, 1 or 2 interns, to go get the blood cross match, get all the blood products in place, and also told my postgraduate students to start the PPH drugs. So at this point of time, you have to take it for granted that maybe nothing was done and just give it a chance. So this is a atonic postpartum hemorrhage. So we did start with the drugs, and once the patient did not respond to just basic drugs, I did start with surgical intervention. And surgical intervention is when you start with tamponade or something like that, which is the basic surgical intervention. Then you move on. So I did start with a tamponade, which worked. Thank God for that. And after that, I quickly called my second on call, who was my unit chief that day, told him that this is the case and this is what I have done, and quickly debriefed the patient as well. And in between all this, also have a surgical team, your anesthesia team, informed that in case the patient needs a laparotomy, you will be shifting the patient. So all this has to go on very simultaneously. And this is just a scenario that I have, which I faced, that I wanted to start with. And there is no room for panic here. There is no room for mistakes as well. So this is something you should know very well. So let's start with the theory part, with what is postpartum hemorrhage and what is the definition like. Traditionally, postpartum hemorrhage has been defined as a blood loss of 500 ml or more during puerperium, and severe PPH is a blood loss of 1000 ml or more. So this is very important, this 500 ml landmark. So 500 ml or less, a body can manage, a woman's body can manage, but above 500, yes, she will start deteriorating. So anything which is severe is more than 1000 ml. More recently, postpartum hemorrhage has been considered severe if there has been a sign of hemodynamic compromise. So as I told you in this example, I was very sure that she is hemodynamically compromised. So before just going on giving her any kind of drugs repeatedly, I did take a a call to go for surgical intervention at that time, because I did not feel that her hemodynamic was good. So she was compromised, and that is when they deteriorate much more faster. So even if the PPH is not severe in front of your eyes, but you feel that the hemodynamically the patient looks compromised, that means you have to take measures more fast. The blood flow to the placental bed. So this is some physiology here. So the placental blood bed at term, it almost receives 750 ml per minute at term. This is why PPH is important also, because as soon as the the woman starts losing blood, it is very high, the blood loss, because of this. And the cardiac output towards the uterus is almost more than 50% at that time, because it's pumping blood to the uterus. And because of all the contractions and relaxation and all the labor process, this is very important that the blood flow is this much. And when after the placental separation, or before the placental separation, sometimes the bleeding does not stop, this becomes an issue. Given the maternal blood volume may be approximately 7 liters, and blood loss may be life-threatening with unreplaced blood volume loss as little as 30%. So because of this issue, the cardiac output is very high towards the uterus. Even a 30% of blood loss can compromise the woman. It can be seen that a mother can become critically unwell in just a few minutes if blood flow to the placental bed is not rapidly arrested with placental separation. So how do we classify postpartum hemorrhage? It is usually based on time and blood loss. This, I'm sure, is the same in Australia and here. So you have something called primary postpartum hemorrhage and a secondary postpartum hemorrhage. Primary postpartum hemorrhage is loss of 500 ml or more blood loss within 24-hour window. This is either after vaginal birth or a LSES. Secondary postpartum hemorrhage, however, is after 24 hours and before 6 weeks postpartum. So this is the definition, which is standard. Um, Again, now this is based on time, and this is based on the blood loss. So you have minor PPH, major PPH, and severe PPH. Minor is between 500 to 1000 ml and with no signs of clinical shock. Major PPH is more than 1000 ml with no signs of clinical shock again. Severe PPH is, however, there will be signs of clinical shock, hemodynamic compromise, or a hypovolemic shock. and the blood loss will be more than 2000 ml. So this is something to be very worried about, and you can't be doing any primary measures at this stage. So you should know what type of blood loss has happened, how much the woman has lost when you're either receiving the patient or when you're seeing the patient at that moment. Hypovolemic shock is a life-threatening condition caused by reduced circulatory volumes leading to inadequate tissue perfusion. So, like I told you in that example, her peripheries were cold. That means there was inadequate tissue perfusion. That is one of the main indicators for you clinically that this woman is going into hypovolemic shock. So, what are the risk factors? As obstetricians, especially when you are in your antenatal clinic, that is the best time to do risk assessment. So we call this proactive risk assessment or proactive risk management. This is when you start finding if there are any risk factors in this woman which you have to be aware of. You can do something right now which can, you know, avoid this whole postpartum hemorrhage or avoid any kind of complications in her delivery or towards term at least. So most cases of postpartum hemorrhage, they have no identifiable risk factors. This means that we should be ready for any woman to go into postpartum hemorrhage, which is what we are taught when we start obstetrics. But however, recognition of risk factors is important in planning suitable birth facilities and labor recommendations and preparation. Now, like I told you, I was in a rural center, and I told you the blood bank was quite away. So when am when I know that I'm delivering, for example, a woman who is anemic or who is, twins, or if there is a polyhydramnios or something which I'm sure that she may go into postpartum hemorrhage. That means I will be more aware of how the situation is right now, whether the blood products are available, should I plan the birth here, or maybe I should refer this patient. So all this is very important. So the place of birth is very important if you have any risk factors in that woman. Early implementation of risk management strategies may improve the early detection and treatment so that PPH is less severe, like managing your anemia or any other risk factors. Assessment of risk factors is an ongoing process which will occur throughout the antenatal, intrapartum, and postnatal period, and it is done in consultation with the woman. Not only antenatal, intrapartum also you should be aware any prolonged labor, any anywhere there is a tear or any instrumental delivery, any macrosomia birth, intrapartum, you have to be aware that she can go into postpartum hemorrhage. And postnatal period also is very important, like we discussed the timeline for postpartum hemorrhage, primary and secondary, it is within 24 hours. That means you can't just deliver a woman and just leave her somewhere. No, you have to, after that, monitor her as well. Any woman can have a postpartum hemorrhage within 24 hours. Yes, secondary postpartum hemorrhage is not that common unless there is some other risk factor, but be aware for primary postpartum hemorrhage, because if it happens in your center, then there is no excuse. Proactive risk management is women with significant antenatal risk factors should be counseled and arrangements made to give birth in a facility with rapid access to blood and blood products and equipped with high dependency or intensive care facilities and access to specialist services. Yes, a HDU or an ICU is also very important. Usually shift a woman who has had a massive postpartum hemorrhage to ICU for observation, which is the best way to observe actually, because she will have one-to-one care there. Rural and remote obstetric services should develop management plans to reduce delay in accessing specialized staff and services in the event of PPH. So managing antenatal risk factors. Detect and treat anemia antenatally in women with hemoglobin levels less than 9. This is one way where you optimize your hemoglobin in your patient, and she will be able to handle any decent blood loss. Even up to 1000 ml, she can handle. Women with inherited hemorrhagic disorders like hemophilia von Willebrand's disease. It's a little rare here, but not that rare in other countries, especially Australia and UK. They require specialist care with a hematologist, obstetrician. Here, all your multidisciplinary thing will come into play, where you will have a hematologist and you will have expert midwife as well and an obstetrician. Throughout pregnancy, and management plan is documented in their medical records. Always have a management plan documented. That's very common to do that there. And if she has any inherited disorders, that means she'll need more care. Women at risk of an abnormally adherent placenta should have a multidisciplinary management plan documented in their medical records. They should be referred to appropriate clinicians. So, adherent placenta is another reason where postpartum hemorrhage can happen. There won't be any placental separation at that time, and atonic PPH will start. And at this moment, you will need a very good setup for delivering her, trained obstetrician who can do obstetric hysterectomy. Very commonly, I have again come across this scenario where I had to do an obstetric hysterectomy for a woman with a adherent placenta. And it's very common in a previous LSCS with anterior placenta. And you have to be aware that she may she may need an obstetric hysterectomy. So sometimes the blood loss cannot be managed, and it needs a very good center to manage such a patient. So if your center is not well equipped, better refer such patients. Risk factors for primary PPH, there's a chart here. I'll just go through this quickly. Few things. Antenatally, what you have to be looking for in your clinic is a BMI more than 35. Obesity is, yes, some people who are obese can go for PPH. Any history of previous PPH, any multiple pregnancies, polyhydramnios, macrosomia more than 4.5 kg babies, where the uterus is very much distended. Uterine anomalies like fibroids, where it will not let the uterus contract properly post placental separation. Any antepartum hemorrhage can lead to postpartum hemorrhage. Any abnormal placentation, like we discussed. Any known coagulopathy, von Willebrand's disease, any ITPs, where there is platelet disorders. And thrombocytopenias, low platelet anticoagulation therapy. If the patient is on anticoagulation therapy, we usually stop it 24 hours or 12 hours before birth, depending on what type of anticoagulant she is on, but still be very much aware that she can go into a postpartum hemorrhage. Any hypertensive disorders, maternal anemia. Intrapartum is any oxytocic use for augmentation. So oxytocins, there can be a boon or a bane, actually, where you can augment your labor with oxytocin. She'll deliver faster, but also leads to postpartum hemorrhage sometimes. It's kind of a paradox because we use oxytocin in postpartum hemorrhage. But yeah, any injudicious use of oxytocin where you're not titrating it properly and you're just going on giving oxytocin just to deliver her, that can cause postpartum hemorrhage. Any induced labor has high chances of postpartum hemorrhage. Prolonged latent phase of labor, this is prolonged labor. Any arrest during the descent, any PROM with pyrexia, any instrumental birth where you're putting a forceps or a vacuum. Episiotomies also can bleed and cause hemorrhage. Cesarean section itself is a small risk factor for postpartum hemorrhage. Precipitated labor or sudden, labor which suddenly accelerates, that is also a cause. Shoulder dystocia, placental abruption, uterine rupture, and prolonged third stage. Postpartum, your things like retained placenta, any manual removal of placenta where you have to literally put your hand inside and remove the placenta can make sure that the uterus will not contract. Atonic PPH is very common after manual removal. Any bladder distension. So yes, this is important. As soon as there is early PPH, we kind of drain the bladder again before we do any tamponade or something like that, because bladder can press on the uterus and make sure the uterus does not contract back. Medication-induced hypotonia, like magnesium sulfate, if you're using for your eclampsia or preeclampsia. Magnesium sulfate, as we know, is also a kind of a tocolytic, so it will make sure that the uterus does not contract postpartum. So be very aware if she's on magnesium sulfate. Perineal cervical tears, any uterine traumas, uterine inversion. Uterine inversion is not that common, but can happen. So you should be aware of the 4 T's of primary and secondary PPH. So tone, tissue, trauma, and thrombin. These are the 4 things. Tone being the most common cause, which is 70%, that is atonic postpartum hemorrhage, which we come across very, very commonly. So this is bleeding related to uterine atony, and causes or risk factors are, like we discussed earlier, over distension of the uterus, any infection, any anatomical distortion of the uterus, bladder distension, and uterine relaxants if we use. Any tissue, it's approximately 10%. This is related to any retained products. So if you have any kind of retained placenta, if there is any even cotyledon or even a succinate lobe, which is an accessory lobe, which is stuck and it's not coming out, the uterus will not contract. Any trauma that you have done, you have given a episiotomy, which we do very usually, but sometimes that can bleed if you don't suture it properly. It can cause hematomas as well. Extensions or lacerations. So if you have put any instrument, or if you have pulled the placenta without doing control cord traction or something like that, then it can cause uterine inversion. All this can be around 19%, and that will come under trauma. Thrombin is very less, 1%. That is any coagulation abnormalities usually, which is not very common in India, but common abroad. Pre-existing conditions like any thrombophilias or any kind of coagulopathies, conditions acquired in pregnancy like gestational thrombocytopenia, HELP syndrome, DIC, if again after HELP or after even PPH can cause DIC. So if she's had some early PPH and you have not noticed, she may be in DIC already. Therapeutic coagulation, which is given. These are the causes. So now what we can do is once we are in management part, I'd like to discuss it in two broad things. One is that prophylactic management. Prophylactic management is, it's not happened yet, but you really want to be quite cautious. You're thinking that she may go into postpartum hemorrhage, and you just want to be cautious, and you just want to give the drug so that it doesn't progress, or she doesn't go into postpartum hemorrhage. So here is where all your risk factors, which is been assessed throughout pregnancy, intrapartum period, all that comes into play. So if you're thinking that she's in this risk factor circle, then yes, please go for prophylactic management. Explain to the patient that she does need this, because especially countries like Australia, UK and all, you do have to take consent to give post PPH drugs, at least a verbal consent, or there will be a birth plan sometimes stating that they saying that I don't want drugs, I want a natural birth, because these drugs can cause very bad nausea. Also, sometimes they are aware of that. Someone else has shared a very bad experience, and they are like, no, we don't want any drugs. So at that point of time, if she is in a high risk, you will have to counsel her, take consent for all this. And definitive management is next what we'll discuss. That will come when you identify postpartum hemorrhage already. So this is before that. So no PPH risk factors. Discuss third stage management with her if she wants, but in developed countries, they don't do third stage that often. But in India, we are doing third stage management for everybody. That is giving oxytocin, 10 international units IM as a start dose during the anterior shoulder delivery or just after the delivery. But if she is having any kind of risk factors for PPH, but she has no contraindications for drugs like ergometrin or centometrin. So as you know, ergometrin should not be given in case of very severe hypertension or cardiac abnormalities, or sometimes even very severe anemias. If she doesn't have any contraindication, you can go with ergometrin. Be cautious and supplement it with an antiemetic like condom, because it causes very bad nausea. Other prophylactic medication is a carbetocin, which is if she is having contraindications to ergometrin, you can give carbetocin 100 micrograms, slow IV or IM. And it is not currently available in SA because of some drug this thing. Otherwise, it is given. It does act very well, actually, carbetocin. This is what we usually prefer, especially in cesarean section birth. So this was prophylactic management, so that just give one PPH drug just after the delivery so that the uterus contracts by itself and does not have any issues. Definitive management is once you recognize postpartum hemorrhage. So what happens? This is the line: recognize postpartum hemorrhage, communicate. This is asking for help. So when I told you about that scenario, I did jump that stage because it was a first of all, it was only me there. I could not call anyone for help, but I did call my second on call. And as soon as I was, I knew that I'm in charge of that scenario, and I have been able to reduce the bleeding to some extent. I did call my second on call, who was my unit chief, and told that I have started uterine tamponade, and this is what has happened. Sometimes there is no time to even call for help, or you will be in a setting where there is no help available. So I did skip that stage. But most of the time you will be in a well-equipped center and you will have some colleague or someone second on call or somebody. So always ask for help, communicate and tell that it's a PPS scenario, I need help. Next comes resuscitation. Basic resuscitation should be started as soon as possible. Monitoring and investigation, send the bloods, cross-match, everything. Manage the PPH per se. First, recognize the cause. What is it? Is it atonic PPH? Is it traumatic PPH? Is it because she was on anticoagulants? Is it because of something else? Definitive management begins at that point of time. So let's discuss atonic PPH more because that's most common. First line, it will be a conservative management where you start bimanual compression and uterine massage, which is the most basic conservative thing which we can do. Second line would, then after that comes your pharmacological intervention, then comes your surgical intervention here. So this is a picture of bimanual compression. What you can see is there is a gloved hand of the obstetrician. This is one gloved hand just in the vaginal end, and another hand is on the abdomen where they are like literally insinuating this here, and the uterus is in between. Can you see that? So this is just causing some compression. So what happens is when the placenta does separates and the uterus is atonic, means there's no tone. So as you know, there is living ligatures in the uterus, and all the smooth muscles of the uterus has to contract, and then the blood vessels in between will have to kind of get jammed in between those smooth muscles. That is when the bleeding stops. So as we discussed, because there is almost 750 ml of cardiac output at term to this, if all the blood vessels here is open, so you can imagine the amount of blood loss from here. So what happens is compress it. Once you are manually compressing it, sometimes it will kind of realize that it has to compress, and it can aid your pharmacological management. It's more towards aiding the pharmacological management. We don't do this only by itself, but we do start it by itself. This is a picture of a uterine tamponade. So this is a probably balloon catheter, but we do have a lot of things called condom catheters. We have Seng's taken Blakemore tubes. We have something called SR cannula here. That was what I used in the medical center, which was available. And what we do is it is a cannula with just some kind of fenestrations, and we put that inside and connect that to a vacuum, and that will kind of cause vacuum inside, and what will happen, it will pull the uterus a little bit, and that causes uterus to contract for some time. So once it is contracted for some time, maybe within 24 hours or something like that, we do remove it. And this is causing a little bit of tamponade with just distending the uterus. It will distend to the size of the uterus and cause, it is pretty much very similar to the bimanual compression. And SR cannulas work in the opposite way. It will cause vacuum inside, and it will, help the muscles contract. Pharmacological management. Now, this is very important in your AMC exam. They will tell you that there will be, this was done till this part, and now they will give you a scenario that what will you do next? What is your next step? So you should know what drugs were given earlier and what drugs you can give after that, how much you can repeat, because all these can be repeated multiple times also, and you should know which one to give next. So first started with usually oxytocin. If it was not given in third stage, so it is slow intravenous injection or IM. If it was already administered in the third stage, you can repeat the dose. Intravenous infusion as per local protocol. So oxytocin can be given up to like 40 units in an IV infusion. Ergometrin is usually given IM, or you can give slow IV as well. You can repeat it every 5 minutes, up to a maximum of 1 mg. And it in absence of contraindications, obviously, which is what we discussed earlier. Any severe hypertension or cardiac abnormalities, you can't give. Misoprostol will act rectally. Actually, we give even sublingually and even vaginally. But when she's bleeding, obviously not vaginally, rectally and or sublingual will work best. Prostaglandins are, and its analogs is the most potent. This is very good. We use it very commonly here. but also they have serious side effect profile. The problem with this is bronchospasm and very bad nausea and vomiting. So some significant history of asthma you can't give. It is contraindicated. Administration is intramuscular. We can also give it intramyometrial. We do give this a lot in cesarean sections. If it does not contract within the first few minutes, we do this, give intramyometrial, but this should be under the responsibility of the administrating clinician. But intramuscularly, you can repeat every 15 minutes up to almost 2 to 3 doses you can give this. So these are the drugs which you can give, and very important to know the steps in this, what has been given next and what you can give after that. Surgical interventions are something which we'll do next. So the thing is, when I told you about the scenario that I faced once, I did tell you that I just did not repeat any pharmacological doses. As soon as possible, I started surgical intervention there. So should be very careful about, it's not something that stepwise approach that, the patient is deteriorating and I will be starting with, 1, 2, 3, 4. No, it doesn't work that way. Should be very good clinically. You should be able to assess the patient. You should know what is her hemodynamic status. She's deteriorating too much, then I would rather skip all these pharmacological things and go for a surgical intervention. And that would be better to save her life than going stepwise approach. Surgical intervention should be initiated sooner than later. So this is very important. When you start the surgical intervention, almost kind of makes or breaks. It's a very fine line between morbidity and mortality here, especially hysterectomy in cases of any uterine rupture, placenta accreta, and uncontrolled massive hemorrhage. So these are the scenarios which we have faced. Any uterine rupture, we can't obviously do any kind of conservative management. You have to go for a laparotomy at this stage, do a obstetric hysterectomy if you're not able to repair the rupture on time. Placenta accreta sometimes does go into obstetric hysterectomy because we are not able to remove all the adherent placenta, and sometimes it is very much into the myometrium, and we have seen cases which does need hysterectomy as soon as the birth of the baby happens. Atonic PPH, yes, you can still wait. If there is any, you do have that window to wait, you can try with drugs and, balloon tamponades or brace suturings. Following list is some available procedures, but this is not necessarily, like I told you, it's not necessarily a stepwise progression, but this is what is given in a textbook. So the both order and the utilization will depend on services, clinical experience available, and individual clinical circumstances. So the balloon tamponade is what we showed you earlier, and that is something we start with. Next is hemostatic brace suturing. So this is very common in a vaginal delivery, balloon tamponade, because you don't have access to the uterus from the abdomen. Easier to do a balloon tamponade when you have just delivered her vaginally and you can see a massive PPH. But if you're doing a C-section and the uterus is not contracting, I'd rather do a hemostatic brace suturing. So I usually go for a modified B-Lynch suture here. And it's easier to put it. Modified B-Lynch is easier to do. If that doesn't work, then you start with your artery ligation. So start with the uterine arteries, then you go for internal iliac arteries if uterine arteries doesn't work. This is important. You need to go dissect posteriorly, and not very easy, and you can't do this very fast because lot of vital structures like your ureter and all will come in between. And then selective arterial embolization. This is only in institutions which it can be achieved. You also have to need a radiological expertise and equipment for this because you can't access embolization. You need to already, put the catheter and keep. So this is very useful if you are doing a placenta accreta case or a placenta previa case where you are finding central placenta previa, where you are sure that sometimes after placenta separates, very difficult that the uterus will not contract. Accreta case where it is very adherent to it is going into the myometrium, and you're sure that you cannot remove most of the placenta, and you will have atonic PPH, and you will need to buy that time to sometimes before going into obstetric hysterectomy. So embolization does work very well. And now this expertise is available in so many hospitals. Hysterectomy is the last resort, where if nothing works and she is going into DIC or she's none of these things are working, then better go for hysterectomy sooner than later. So this was the management of atonic PPH. Any other causes like genital trauma, this is traumatic PPH. This should be again just sutured. Usually any kind of any vagina, cervix, perineum, you should be able to visually inspect the source, find the source and suture it. So this is very important here. If it is not atonicity, then it will be something which is traumatic. Also, the way she is delivered, everything is important. For example, someone a twin sorry, a polyhydramnios or a twins also, for exact example, she's delivered and she's having PPH, I would be more biased towards atonic PPH diagnosis, because most of the time it is that. But if it is nothing to do with atonicity and the uterus is well contracted, this is another question you will get in your AMC part 1, where they'll say that the uterus is well contracted, and then they'll ask, what are you doing next, because there is what are you going to do next, because there is bleeding from the vagina. Then you will say that I'm going to inspect the vagina, cervix or the perineum, or whatever next choices that you have. And once you inspect for the bleeding source, then you are sure that there is some laceration or there is some tear or something like that. Repair it either in the labor room or operating theater, depends on what kind of anesthesia you need for that, whether you have a cooperative patient or not, or again, the place you work there also, they will have some local protocols sometimes. If the patient is having a shock and vaginal bleeding is normal, then obviously think of some ruptured uterus, a broad ligament hematoma which has happened, which is rare but still a possibility, subcapsular liver rupture, ruptured spleen, ruptured splenic artery, hepatic artery, aneurysms, anything like that, something to do with something concealed and it's in the abdomen and she's just delivered and she's in shock and you don't know what is the reason, because there is very minimal vaginal bleeding. Very common in a previous C-section giving a VBAC trial, where rupture suddenly, even after the baby comes out, you can have a uterine rupture. Or if you have done an induction over induction, used injudicious oxytocins, sometimes uterus can rupture even in a preemie. Tissue, which is retained products of conception. This is usually due to any retained placenta, cotyledons, membranes, any accessory lobe which you have missed. So the placenta has been delivered, then assess for any missing tissue once, just look at the placenta if it's complete. The placenta has not been delivered, then you have to do a control contraction, try giving another dose of oxytocin sometimes and removing it. But empty the bladder, like I said, sometimes the bladder is pressing on the uterus, it will not let it contract. Sometimes your placenta will also not come out. And transfer the patient to theater for manual removal. Manual removal should always be done in a theater under general anesthesia. Can't do it any other way, not in the labor room, nowhere else. So you do need a general anesthesia, because that will completely relax the tract and the woman will also be quite comfortable. Then you do a manual removal of placenta. Thrombin, again, abnormalities of coagulation. So there is a woman trial which has shown tranexamic acid to be very efficient in reducing any kind of bleed due to coagulation. So if she is having any ITP, or if she is having gestational thrombocytopenia, also von Willebrand's, any kind of thrombocoagulation issue which we discussed, giving 1 gram of tranexamic acid before the procedure intravenously has reduced. So nowadays, actually, we do give it here, even sometimes when my patients have a little bit lower platelet and previous LSCS or something where I'm expecting some kind of more blood loss. We are giving it now before C-sections, so that the blood loss, even the small capillary bleeds, are much lesser. So you can repeat after 30 minutes if bleeding is persistent, but definitely it is going to work well if they have any coagulation issues. Replacement of platelets and clotting factors are also important. Early replacement of clotting factors, platelets is essential for management of severe PPH. So we are not going into very much of detail of the massive transfusion protocol for PPH, because again, for the time constraints, that would be a definitely different topic, but you can read up on massive transfusion protocols. It is very important to know also that what kind of blood products are necessary depending on the fibrinogen level, and also depending on the patient's clinical scenario. And if massive PPH is happening, how much platelet you have to give for every PRBC that you transfuse. what are the blood products which you have to keep in in store, and also if you have need a fibrinogen concentrate, at what level you have to give that. It is better to know that. But as much as I have come across, they don't go in so much detail because it's not too much obstetrics gynec. It is at basic level, but it is good to know this. So any particular attention should be given to fibrinogen level with replacement where fibrinogen is less than 1.5. So we have target levels in PPH, where we have to send, if there's a massive PPH, you do have to send a coagulation profile, a renal function test, and all that. And your clotting factors, obviously, clotting, you have to know PT, INR. If the fibrinogen is less, then you have to replace fibrinogen. So that was all about primary postpartum hemorrhage, as to how you can identify, how you can antenatally, you can, stratify the woman if she has any risk factors, how you can identify postpartum hemorrhage, how you can prophylactically treat, and how you can go for definitive management once you recognize it. Secondary PPH, however, is a little rare and it is usually associated with endometritis. This is again a common question. If they ask you secondary PPH question, most time it will be something to do with endometritis, which is usually common with any kind of infection which is developed postpartum. It can be with or without retained products of conception. If it is with retained products of conception, you will have a question which says that she's having a lot of bleeding. Just endometritis without retained products of conception will be just patient will have some pain abdomen, abnormal smelling discharge, abnormal lochia rather, and also some fever sometimes. Conventional treatment includes any antibiotic therapy. This is because endometritis is most commonly because of some infection. Antibiotic therapy started. Some kind of uterotonics can be given here if there is retained products of conception, and sometimes certainly it can become atonic also because of retained products of conception. In situations of excessive or continued bleeding, surgical intervention will be necessary even here, and particularly in evacuation of retained products. If there is any retained products, maybe it needs evacuation at that moment, otherwise it will not contract. So ultrasound is an important way to diagnose secondary PPH. At least to know what if you have any retained products of conception or not, ultrasound is usually done. So we're almost ending the presentation, but I just added this. It is from South Australian guidelines. So this you should know, it's important. It's a very good chart which shows PPH management in a kind of, summary kind of a thing. And you can, if anybody is going for exam or something here and join this, it's very important. So first is call for help. Again, like I told you, there is no, this thing here that you have to call for help wherever you are. That will be your first response. So make the woman flat. A Trendelenburg position is important. Keep her flat and keep her comfortable and keep her a little warm. Keep warm is very important here. Start oxygen. It's important because, again, once she's going into shock, there will not be oxygenation to the end organs and DIC will set in faster. Always keep her warm and give oxygen until she's breathing properly, at least. Then oxygen will be kind of maintained, because blood loss is low, your hemoglobin will fall, and then there is no oxygenation otherwise. Insert an IDC, indwelling catheter, very, very important, because you will be doing a fluid resuscitation, you'll be giving fluids, so bladder will fill up very fast, and then you'll be wondering why all your medications are not working and why it is not contracting. That would be because of a filled bladder. And also very good for input output charting to know if she is going into DIC or a renal shutdown at that time. Send for a full blood count and monitor vital signs and group and cross. That is quite obvious. Measure and record blood loss throughout the process. This is very, very important for us to know what type of PPH she is in and what you are dealing with, and what are you still in the pharmacological process, or should you just jump ahead and do something more, like surgical intervention, more drastic. So prophylactic uterotonics, have they been given at third stage? This is important. Question will usually mention that she had taken or she had not taken. So if it was given, if the third stage management was done, and if there is no contraindication to ergometrin, then go with a symptometrin. If in case there's contraindication to ergometrin, you can repeat oxytocin here. In case third stage management was, this is when third stage management was not done, sorry. Now, if the third stage management was done, then you can give oxytocin, and you can give if symptometrin is available, and that you can give. So oxytocin and symptometrin are pretty much in the same level here, depending on the third stage, whether it was done or not, if it was oxytocin was given or not. So IV access, like I told you earlier, you have to have a 216 gauge or an 18 gauge for blood transfusion. This is the best. So both should have access for blood transfusion. Collect a full blood count, your urea, electrolytes, fibrinogen, group and cross match. Consider any kind of coagulation studies also. So warm fluid replacement is the best. Pack cells are the best, but until you get it, warm fluid replacement, of course. And then if nothing is available, O negative. If in case this works, start monitoring, and also anyway, start monitoring and do heart rate, respiratory rate, and BP, O2 stats every 5 minutes, and temperature also should be taken every 15 minutes, and look for signs of shock here. Any ongoing thing also, she should be monitored for the next 24 hours, even if it stops at this stage. Here, once you are done with this, they are again telling you to add tranexamic acid. Tranexamic acid is very good supplement for any uterotonics that you give. So your initial will be symptometrin, oxytocin, and tranexamic acid. In whatever what was given earlier, just choose the next thing. So next, so if again, this is when you start identifying what kind of PPH it is. This is kind of the diagnosis basically. Is it tissue, tone, trauma, or thrombin? Depending on that, you will do the next management. This is the definitive management. So if it is tissue, apply any control cord traction, and try to deliver the placenta. Once the placenta is out, usually it will also contract by itself. Consider a manual removal in theater if it is adherent or trapped. Inspect the placenta if the placenta is already out. See for any missing cotyledons. If in case it is stone, then massage the fundus. Start giving your next things, which is carboprost. And also, if carboprost can, I told you, have a lot of side effects. Diarrhea can be one, so they advise loperamide here. Inspect in case of trauma. If you're sure that there is no tissue, your placenta is complete, and sometimes they'll give you a question that the tone of the uterus is fine, the uterus is completely contracted, there is you have inspected the placenta, and then there is no incomplete placenta, or cotyledons are not missing. So next, always look for any genital trauma here. Inspect the cervix, vagina, and perineum for tears. Repair tears any promptly, and any uterine inversion should be replaced. Transfer to theater if there is any rupture or hematoma. Thrombin is important to identify if the blood is not clotting at this point. So then review that if she has any coagulopathies that you have missed or anything like that. She has had any severe preeclampsia, HELLP syndrome, placental abruptions, any sepsis, IUFD, amniotic fluid embolism. This is an important topic again, because it will not present like this. Most of the time, amniotic fluid embolism will be direct DIC, and the patient will collapse within 30 minutes of labor. DIC and hereditary bleeding disorders, which if you have missed any of this, then the cause could be thrombin. So if the bleeding continues even 30 minutes, so if you are doing any kind of pharmacological management and you're seeing that even after multiple doses, the bleeding is not stopping. So basically, even 30 minutes after the first dose of tranexamic acid, you can repeat the tranexamic acid. But if it is not controlled in spite of all this thing, transfer to theater and look for any other thing. So we will definitely go for a uterine tamponade at this stage. Any packing, vaginal packing if possible. Repair any tears, any manual removal of placenta if there's any retained products. Again, if it's a C-section, Beeline suture if all this has failed. Go for Beeline sutures and or ligating vessels or any aortic cable compression if possible. Last resort will always be a hysterectomy. So ongoing care once bleeding. So you've done all your stuff and you have controlled your postpartum hemorrhage, hopefully. And at this stage of time, you cannot just abandon your patient. You have to always keep her under monitoring, if possible, in a HDU or an ICU. Ongoing care once bleeding is under control. You have to administer any maintenance used tonic. So I told you that 40 international units of oxytocin can be given. So what we do is we put it in an RL and we give a continuous infusion sometimes, just so that the uterus does not relax. So that's what is mentioned here. Consider misoprostol, PR or buccal or sublingual, up to 1000 micrograms can be given. So consider transfer to a higher level if, as per local protocol. Again, after a massive PPH and especially a massive transfusion, a VT prophylaxis is definitely something you should consider. Once your PPH is under control, you've given so many things for the blood to clot. For example, tranexamic acid repeated doses, then she can end up in a VT, especially if she has other risk factors for VT. Then you should be careful, start your VT prophylaxis, but we will give 24 hours definitely after a PPH to start any VT prophylaxis. Increasing the frequency of postpartum observations. Develop a care plan for ongoing management and follow-up. Discuss plan with the woman. So this is also very important in exams when you're giving a foreign exam, like even USMLE or any other thing also in Australian exams, where you will always have to update this woman at each stage if she's conscious that I'm doing this and this is what is happening with you. We're very sorry. We are trying to do everything possible to save your life, and this is, a critical scenario. We want you to cooperate. These are the words you should, reassuring words you should use at every level. You have to tell her that she's being given so many drugs. Otherwise, she will panic. Everybody are panicking in the labor room. Everybody are running around. She will obviously wonder what is happening because she was told that everything is normal and her birth is going to be uneventful. So that at least what she had perceived, but that is not the case now. So you have to keep debriefing her at every level possible. But also after the whole thing has happened and you have controlled the whole situation, definitely have a debriefing session with her and her family once she's out of danger and discuss what her future plans can be, what further next delivery, next if she has any other delivery in future, then what she can expect. And there can be usually repeat PPH if there is a history of PPH. So until her next birth, she has to be updated regarding everything. So we call that a debriefing session, and always that is something what they have mentioned here. So that is, again, risk of secondary PPH is also high, and she should be, even after discharge, she should be very careful. Report. This is very important again in countries like UK, Australia, and US, where you have to ensure that you are doing something called incident reporting, because this is a near miss if she survives this, and it should be an incident reporting, and it should always be having full documentation of what kind of drugs was used, everything. So when you give all the drugs, everything should be documented. There is always sometimes there's a person who documents it. So if you're a team leader there, you are going to say that to this person that keep time and document. So what time did PPH start, what time oxytocin was given, what time ergometrin was given, how many doses was given, what time tranexamic acid was given, did it stop at that stage, how many doses of tranexamic acid was given, next how much carbetocin was given, did you have to do any surgical intervention when the patient was shifted to OT, everything, or was she managed in labor room, what time she was shifted to the HDU, everything has to be documented and has to be written in the incident reporting. So that is the end of postpartum hemorrhage, primary and secondary. We'll do some practice questions, something which is very similar to your AMC exam, which you can get in AMC exams. So one of the examples is a 30-year-old woman, a primigravida with GDM, that is gestational diabetes mellitus, and polyhydramnios, undergoes a spontaneous vaginal delivery at term. Now she has been given an injection, ergometrin IM, as a part of active management of third stage. Within 30 minutes, she develops brisk vaginal bleeding. The estimated blood loss is 800 ml. So what is an issue here? 800 ml. This is an issue because 500 ml or more is PPH, minor PPH. Her uterus feels boggy on palpation. This is important. And her BP is okay. She's not hemodynamically unstable. 100/70 is fine. And her heart rhythm is 100. What is the most appropriate initial pharmacological management? So Dissecting the question here, she's 30-year-old, she's primey. I wouldn't say there is much risk factors here, but coming here, she is GDM and she has polyhydramnios. So it's an over distended uterus. She undergoes a spontaneous vaginal delivery at term, which is good. Again, because she had risk factor already, they have done a third stage management. That is, they have already given ergometrin IM as part of active management of third stage. But in spite of that, she's developed brisk vaginal bleeding and it's 800 ml. That means this is minor PPH. So they are asking you a question on minor PPH where she's hemodynamically still stable. Heart rate is 100 is kind of high, but still okay. Now they have given ergometrin. What next is your initial pharmacological management? So this is how they will ask a question in AMC where they will give you a scenario that they have managed up to this stage and what will you do next. So your most appropriate next step is what they are asking. Yeah, pharmacology. So they have mentioned that it is pharmacological management. So this is what they want. So if they give you some options regarding giving surgical management here, then you should be a little careful. So the options are ergometrin, misoprostol, tranexamic acid, oxytocin, and carboprost. So here, like we know, next step is oxytocin. As we discussed in the chart previously, after ergometrin, if there is no contraindication, if you can even repeat a dose of oxytocin if it was given earlier also. So oxytocin will be the next. So it can be given IM or IV. So if they ask the question like this, that oxytocin and they have already given oxytocin, so your next would be to go for a tranexamic acid IV. So that is also something which they can twist and turn and ask. So rationale of this is uterine atony is the most common cause of PPH, especially given the risk factors of polyhydramnios. Oxytocin is the first line pharmacologic agent to stimulate uterine contraction, as ergometrin was already administered as a part of third stage. So next question gives you a scenario of a 26-year-old primary gravida presents to emergency department with a persistent vaginal bleeding and foul-smelling lochia and fever. She delivered a healthy infant vaginally at home 10 days ago. It was a home delivery. Examination reveals that she is febrile with tachycardia, uterus is soft and tender, and ongoing bleeding is there. How is the hemorrhage best classified? So they are asking you what type of PPH this is. Always when you are reading questions like this, you should know what type of what they are asking. So sometimes I do like to read this last thing so that I know what I'm looking for here and looking for here, especially in very long scenarios when they give. So what is the hemorrhage best classified as? So they have given you a classification here. And otherwise, the question gives you a scenario of a 26-year-old woman. She's primey. She's presenting to the emergency department. That means something is wrong with her, with a persistent vaginal bleeding, a foul-smelling lochia. So this is obviously a secondary PPH, most commonly because of endometritis, because she's telling that it is a foul-smelling lochia and she has fever. So she delivered at home 10 days ago, maybe not handled properly for all you know. Examination reveals that she is febrile, she has tachycardia, and the uterus is soft, tender, and there is ongoing bleeding as well. Yes, you do have to look for retained products here because you haven't, she has not been delivered in a center. Nobody has examined her placenta probably. Maybe there are missing cotyledons or some clots inside, but also endometritis with or without retained products is probably the diagnosis here. So they have not asked that much in detail, so you can go for secondary PPH. So answer is secondary PPH. So secondary PPH, anything from 24 hours to 6 weeks postpartum is secondary PPH. So may or may not include retained products here. So next, if they ask you what investigations you will do at this stage, it will be a USG to rule out the diagnosis. And obviously, again, you will send a blood panel to know her CRP and her total count and her hemoglobin and all that also. Next scenario is a 33-year-old woman undergoes a vaginal delivery. She develops uterine atony and PPH. It is unresponsive to oxytocin. Her medical history includes severe bronchial asthma. Which of the following uterotonics is contraindicated? So they are not asking anything else here. They are asking you what kind of uterotonics is contraindicated because she has bronchial asthma. So we discussed this earlier, but let's go through the question. It's a 33-year-old woman, vaginal delivery she has undergone. Now she's developed uterine atony and because of that postpartum hemorrhage. So it's in the atonic postpartum hemorrhage. already given oxytocin but unresponsive to oxytocin, but she has bronchial asthma. So what you should not give here is carboprost. So because it's a prostaglandin and it can worsen any kind of asthma or can cause bronchospasm. So other things won't cause any bronchospasm and they are safe to use in her. So carboprost, a prostaglandin analog, can trigger bronchospasm. It's contraindicated in asthma. Next scenario is a 34-year-old woman. She develops ongoing bleeding after an assisted vaginal delivery for prolonged second stage. Uterotonics have been administered and the uterus is firm. Speculum examination reveals oozing. So what is the most likely cause of her hemorrhage here? So she's a 34-year-old woman. Ongoing bleeding is there. This is the clue here, an assisted vaginal delivery. So it could be an instrumental delivery with a vacuum or a forceps. They have not told you what. She had a prolonged second stage and there was an assisted vaginal delivery. Uterotonics have been administered. Yes, maybe it is atonic also because prolonged second stage is a cause of atonic. And uterus is firm. But they are saying that uterus is already firm. That means you can rule out atonicity here. They have also told you that they've done a speculum exam and there is some kind of oozing. So that means the source could be a vaginal tear or a cervical tear or a kind of sometimes even a small perineal tear also could be missed. So what you're looking at is a genital tract trauma. So other things like uterine atony, they have told that it is firm. It's not retained placenta. They have not told you anything regarding that. It's not a coagulopathy and nothing to do with the placenta accreta. So the answer is genital tract trauma. So a firm uterus with continued bleeding suggests usually trauma, that is any kind of laceration as the source and not uterine atony. So very important to look for clues in the exam, in the questions. Usually most of the information is given in the question and they have examined and they have given you all the information. Your work is to look for those things and also see what they are asking you to answer. So here they've just asked you what is the cause of her hemorrhage. They are not asked you anything else. So go for genital tract trauma. A 28-year-old woman develops massive PPH after a cesarean delivery for obstructed labor. Medical management, including uterotonics and uterine massage, fails to control the bleeding. She is hemodynamically unstable. Which of the following is the most appropriate next step? So here you have a 28-year-old woman. She's developed massive PPH. That means more than 2000 ml. Cesarean delivery has been done for obstructed labor. That means probably she was in labor from a long time. Medical management, including uterotonics and uterine massage, has been done. Controls to feel the controls to arrest the bleeding. She is hemodynamically unstable already. So what will be your appropriate next step? So here you have to be very cautious. You can't do something very very initial part here because it is obviously she's unstable hemodynamically. Sometimes they won't give you this directly. They will give you a very low blood pressure, maybe a 90/60 blood pressure, a tachycardia 120, peripheries are cold, like how I mentioned earlier in that example. We had all that and she was going into a hypovolemic shock. So that is something which is clue for a massive PPH anyway. But they have told that she has developed a massive PPH after a cesarean delivery. And again, they have told you it is a cesarean delivery. That means you have the uterus right in front of you. The abdomen is open. Best at next go for a Beelan suture here. Other things are misoprostol rectally. It's not going to help in hemodynamically unstable women. Beelan suture, yeah, yes, definitely. Uterine artery embolization, not a very ideal scenario here unless you're prepared for it. Wait and watch for spontaneous resolution, not an option here. And administer tranexamic acid. Again, here administering any kind of pharmacological thing or doing any tamponade is not going to help because she's hemodynamically unstable and you want to save her life next. So what is the most appropriate next step is a Beelan suture because it's a cesarean delivery and that's the best thing you can do for her next. So B-Lynch compression sutures are an effective early surgical step, and when medical management fails, embolization may be delayed or unavailable. Yeah, so we are done with the questions and the masterclass. Thank you, everyone. Bharti, over to you.
Yeah, thank you, Dr. Priyanka, for this informative session on the postpartum hemorrhage. So I hope this is actually an informative session for you all. So quickly, if you have any question related to the topic, Dr. Priyanka is available for a few minutes. You can just simply raise your hand or just unmute yourself. In the meantime, Shoaib, can you just share your screen for the rest of the information? Yeah, so do we have any questions from the audiences?
Yes, ma'am. Ma'am, good
Yes.
afternoon. This is Charishma.
Hi, good
Ma'am,
afternoon, Charity.
uh, ma'am, I just wanted to know, like, where you have done your it's not related to the topic actually of
Okay.
today's class. Just I wanted to know that have you, I mean, like, where you have done your MBBS, and how about the package in Australia, the salary package? Could you just give me an introduction of yours?
I did my MBBS in Adi Chanchandgiri Medical College. So that is a rural medical college, a little bit away from Bangalore. And I did my post graduation in Mumbai. I did it way back in 2014, actually, 2012, actually. And then I've been practicing since then. I have my own setup now. Actually, I run a maternity hospital in Mysore. I also was a senior resident at Adi Chanchandgiri Medical College itself until last year. So that's like my education background. Salary package, it depends on which system you're working for. It would be somewhere from 120,000 to 150,000 if you're starting as a senior registrar in obstetric gynec. That is the salary package per annum in Victoria. It is very subjective there. It's not exactly same for every hospital. But it depends on what position you're in and what is your seniority level, and it will increase depending on that.
Okay,
Yeah.
ma'am, and the next is that, like, see, I have a doubt that after we clear the AMC Part One exam, so are we supposed to? I mean, like, we'll apply for a job. So, is there any chance like we get the job, or how? What CV should we
Very
have to have?
subjective. Yeah, that your timeline is very subjective, Charishma. I don't think I can comment on that. It's a very individual journey. Some people get after 6 months, some people are still struggling after years together. It is very dependent on the job market there and what is your qualification and how your CV looks. For me, if I have to speak for myself, yes, I do have a long CV of 10 years experience, and I have been running my own setup, and I have 3-4 years of senior registrar in a medical college, and I have done, like, that is how my CV looks. That is just a gist of my CV. But it should be depends on how your CV looks, what they are looking for, whether they are okay with sponsoring you, how much experience you have after your either post graduation or your undergraduation, and what job you're applying for. All this is very subjective. I Nobody can give you a timeline on this, but
Okay.
you have decided, and if you're moving, that's a journey that you have to set for yourself, and you have to find
Okay.
it for yourself. But I would definitely say that there is no shortcut, or there is nothing else here. Just hard work and determination, and just keep going, because you never know. My journey is different, your journey is different. You may get after part one, you may get after 6 months or 3 months of part one also. You never know. You may get the job, or sometimes you may have to do a part two also. And only then you can get a job. It all is very subjective. I don't think there is any hard and fast rule, or every person will have the same journey. It's not that way. So something for you to find out. If you are really into this and you've decided to move, then yeah, it's
Actually,
something
I'm
you have to
planning
be sure about.
to. Okay, okay.
So
Actually,
thank
I'm
you, Dr.
planning
Priyanka.
for.
Thank you for your response. I think she has answered the question in a lot of detail. To add to that, I would say, like she mentioned, the journey is very subjective, and it would require a lot of commitment on everybody's part. and obviously your individual profile and the job that you are applying to. So thank you, Doctor, for your response. So if you have any questions related to the topic PPH, Dr. Priyanka is still with us.
On your screen is our QR code for joining the EduCafic. It's a platform, it's a WhatsApp channel that we have. So you can just simply scan and join the community. Apart from that, if you have any other queries, we are here. And I would like to thanks Dr. Priyanka for joining us for this
Yeah.
informative
Thank you
session.
so much.
Thank you, Dr. Priyanka.
Thank you for having
Okay,
me.
in the
Thank you,
meantime,
Doctor.
yeah.
Thank you.
If we have any other queries related to the course and all, we are open for that. Otherwise, as I've requested you to leave your details in the chat box, so my team will connect with you one-on-one. You can simply raise your hand or unmute yourself. So
Good
we have
afternoon, ma'am.
our yes.
Ma'am, actually, I am having one doubt, ma'am. Like,
Yeah, Dr. Varun.
starting, yes, ma'am. Starting 3 years we have studied in Ukraine, ma'am. But due to war time, we have transferred from another university, ma'am, to transfer to another university that is in Uzbekistan.
Okay,
And
so
when I checked the AMC portal, that is like our university is eligible to apply for AMC one, ma'am. But here the problem is like we have completed 3 years in Ukraine and 3 years in Uzbekistan. Can we write AMC 1 and 2 without any problem, or do we have any problem, ma'am?
like both the universities are available in the World Dictionary.
Yeah, yes, ma'am.
So I
Okay,
don't think there'll be a
so
problem. Yeah.
Doctor, I think,
Dr. Dinesh.
yeah, Dr. Varun, I think the university that would be issuing your final medical degree, you'll have to check whether it is registered there in the World Directory. The WDOMS site, which is there on the Australian website, because they will be checking your final degree. Basically, your degree verification will be there. So if that degree is registered with the WDOMS, so I think you can write for the AMC exam. The best for you would be to check it in the WDOMS registry. If the issuing college whose name would be there on your medical degree is there, then you would be eligible.
Okay, ma'am. Yeah, our university is eligible, ma'am. And one final doubt, ma'am. Like, is it better to write FMG exam in India and then go to AMC? Like, it is very big process. That's all. And or else, can we write directly the AMC one by having some like improving our CV, ma'am?
No, doctor, you don't need to write the FMG exam. You can straight away give your AMC 1 exam. So
Yeah,
you
okay, ma'am.
have to clear the FMGE exam. You don't
Yeah,
need that.
because we don't have CV. That's why like we are thinking, ma'am.
Yeah, but I would suggest that to improve your CV and like it would be a process to improve your chances. Just keep on after you
I mean,
finish your degree. Just
hi, Dr.
yes, sir.
Reddy. I mean, yes, yes. So, if you do not have experience and not yet you pass FMG, so the best pathway for you can opt, study abroad. Like you can go on any non-clinical course to Australia, and simultaneously you need to clear AMC Part 1, and then you can do some observership there. You can improve your CV. It will, improve your chance to get a job.
Okay, sir.
Thank you.
Thank you very much, sir.
Thank you, doctor.
Thank you, ma'am.
So do we have any other question related to the course or about the eligibility?
Yes, ma'am. Ma'am, this is Charishma. Good evening, Akram
Yeah.
sir, and good afternoon, Akram sir, and good afternoon to Bharati ma'am and Raini ma'am. Ma'am, actually, I've completed my 4 years course. 4 years of my education of MBBS in Ukraine in Zaporozhye State Medical University, and then due to the war, we got transferred to Uzbekistan, Bukhara State Medical Institute, and I got the degree, which is a 6 years course, and the degree is from the Bukhara Institute. So my university, both of the universities are recognized in the World Directory Medical School, and I have already applied before for the ECFMG verification also. I mean, I planned for USMLE actually. So the process, both the universities have approved for it, and I could able to write my step 1 also, but I couldn't go for that. So I'm planning for the AMC only. I have given a FMG of one attempt in last Jan 12th. So I couldn't able to make out that exam, and like I'm planning for to write the FMG again in this July. So I don't know whether it's going to happen or not. But I am much more focused in the AMC only. So the thing is that like, do we need to have a proper CV, right? So what courses does as Akram sir have told to a person that we like go to Australia and apply for any non-medical course. So parallelly do prepare for the AMC and like do an observership to get a proper CV, right? So
Yes.
yeah. So like if we go like that, so what courses is academically is
Like,
offering?
I mean, academically can help you to get your admission done in any, I mean, non-clinical course. Whatever course you want, we can help you. So, for example, from my side, you can go
Okay.
like most affordable course like Master of Public Health, or Master of Healthcare Management, Hospital Administration, those kinds of course you can opt. तो इसमें ज़्यादा पढ़ना नहीं पड़ता. You will get a lot of time to prepare yourself for AMC, and you will get a lot of time to go hospital, do your observership, make your strong CV.
Okay. Sir, so like what you suggest to sir, like I have the conferences that I have attended in the med school. So will that be okay for my
Yes,
CV?
yes. I mean, whatever you done, CME, CPD, whether it is points है नहीं है, you must need to mention your CV. But
Okay.
वो सब भी आपको help करेगा. Apart from this, if you have maybe some research, some publication, elective कुछ आपने किया था, all those everything you need to mention the CV.
Okay. Okay. Thank you, sir. Sir,
Thank you.
one more question.
Yes.
Are we supposed to do any research papers that?
No need, अगर आपने नहीं किया है तो no need. But आपने अगर किया था, then you try to publish in any PubMed or Scopus Index journal.
अच्छा ठीक है सर. और एक क्वेश्चन है कि like if we do any workshops like BLS and ACLS, so
Yes,
if we
that
included
will help.
that is also will be helpful.
Yes, helpful.
Okay. Thank you so much.
So, now what you can do, Karisma, you can start preparing for AMC 1. Okay.
Okay.
Simultaneously, we guys can help you to get your admission done, and we do not charge anything for admission. It's a free service from our side. You just need to pay the university fee. We will give you 4-5 university option. Then you choose which university you want to go there. Then in that way, very easily you can settle in Australia, because you will get at least 5 years visa. If you are going for 2 years study in Australia, and once
Okay.
you complete this course, you will get another visa called PSW visa, post study working visa, 3 to 4 years. So totally you would get at least 5 to 6 years to settle yourself in Australia.
Okay. Sir, is there any physical office in Hyderabad?
Yes, I'm
Academically?
coming next week in Hyderabad, Krishna. So we have our first experience center. Guys, if you are from Andhra Pradesh, you can come and meet me. I'm coming next week in Hyderabad. Okay. It's on 11th of May.
Okay. Thank you, sir.
और yes, तो हमारा न्यू एक सेंटर ओपन हो रहा है हैदराबाद के अंदर, और वो है यार कौन सी जगह है, फॉरगेट. आई मीन आवर टीम विल गिव यू द एड्रेस बेसिकली. तो अभी हमने अनाउंस नहीं किया बिकॉज वो 11th को उसका इनॉग्रेशन. Okay, so our team will get back to you and will give you the the address if you want, and you can meet me there.
Okay, sir. Thank you.
Okay, thank you so much.
Doctor, you can
Sir,
just
one
drop
more
in your Dr. Charishma, you can just put in your number and your mail in the chat ID, and our team will get back to you.
Ma'am, do academically provide any courses, ma'am? Like some other consultations are providing CPD courses, and these all during the course we join.
Actually, you can join a lot of other courses, so we will give a list of those are approved by the, the Australian Medical Council, those institutions. So you can do from there. But right now you need to focus on your AMC preparation. And if you do not have any experience, you can go to do master degree. If you already have registration in India and you are working, then without any course also you will get the job. So getting a job in Australia, it may take 1 month, it may take 6 months. Because it is like really individualized your CV. If you have experience, if you have more experience, there's a more chance to get a job. For example, Dr. Priyanka, she got job I think around in 4 months, because she passed in November only last year. This AMC part 1, and she got job around I think in March. So it may take 6 months, it may take 2 months. So it's purely based on your own CV.
Yeah, I am foreign medical graduate, sir. That's why I'm asking.
So in that way, I give you already the best pathway. FMG is me the best pathway. You go there, study and pass this exam.
Observationship.
Yes, improve your CV basically.
Okay, sir. Thank you.
Even there is a chance the same hospital can give you the job if you are doing very good. If the
Okay, sir. Thank
doctor
you.
is happy, all are happy with you, they may offer you the job in the same hospital.
Okay, sir. Thank you.
Thank you.
Excuse me, sir, I have a doubt.
Yes, Dinesh. Dr. Dinesh, please.
Sir, actually, I completed my MBBS in India.
Okay.
Actually, my medical college has been listed in World Directory, but it does not contain the ECFMG sponsor notes. Whether am I eligible to apply for AMC 1?
Means in which year you passed this exam? When you got the admit in this medical college, it was there. It was approved for the same year.
Sorry.
For example, if I am a 12th grade, right, and I want to get admission in MBBS, so 4th year this year, so I want to check this college name is there. If the college name is there, definitely yes, you can.
Okay. The sponsor notes is not there, sir.
I think still we can check basically, so our team will contact you one-on-one and they will check. Okay.
Okay, sir. Thank you, sir.
So, Dinesh, are you from which medical college? It is a new medical college?
It is a new medical college, sir. It was started only in 2018.
Okay. Any other question? Anything, guys, you can ask about Australia, jobs, visa, or about the topic, anything about AMC.
Hello, sir. Assalamu alaikum. I am from Pakistan and I have completed my MBBS, and after that I have completed 4 years of postgraduate training in PEDS.
Okay.
So what pathway should I follow, and whether
How many
this
years you
training...
have? How many years you have experience after your PG?
Sorry, after?
After you did your, you are mentioning that postgraduate training in pediatrics, right? So, how many years you have experience?
I just completed 4 years in this June.
Okay, then you need to go to a standard pathway only.
Whether I can join PEDS training in Australia?
Generally, no, you do not have any experience. Generally, Australia, except for a specialist pathway, those have at least 8 to 10 years experience. So generally they give for that, but you have zero experience.
Yes, and sorry, can I join training in Australia any time next?
I mean, yes, even you can try for the short-term training pathway as well.
Okay,
so
short term.
read about that and find a job, and you also can try for that pathway. But
okay,
the best pathway for you to go to the standard pathway, this Dr. Priyanka, she presented this, She have around 10 years experience after PG, like you. And she also gone through the same journey and she got the job. Okay. So forget about your PG, what just pass AMC 1 plus English and then try for RMO, SRMO, registrar position in pediatrics. So in that way,
Okay, and
easily you can get a job and you can settle in Australia.
after MC1, if I complete 1 year of workplace based assessment, 1 year, then I can get license there.
Yes.
Whether they pay during this 1 year or I have to pay fee of
You
that
need to
hospital.
pay. It is a training you need to pay, but generally you need to work some other hospitals, some clinics. You can get the money. Generally, Australia, whatever you are doing, even if you are working part time, you can support yourself. You are not really required to ask money to your parents or send money here. Even whatever is student are going in Australia, they do basically part time jobs. So maybe initially you need to pay some fees for this WBA. Rest of the things you can manage.
Okay, sir. Last question. Uh, have you any center or just online support in Pakistan?
No, we are online. We don't have any center in Pakistan.
What kind of assistance you provide for MC1?
We provide documentation and we provide coaching for these live classes, study material, practice for mock in our system. And once you pass the exam, we will guide you regarding your job, interview preparation, and CV. All those things we will guide you.
Okay, sir. Thank you. Thank you, sir.
Okay, thank you. And we also provide coaching for English, OET or PT or IELTS, whatever you want to do.
Yeah. I just need it. I will contact.
Okay, thank you.
Thank you. Thank you.
So if we have anyone else who has a query.
Hi, ma'am.
Hi, Dr. Sheikh.
Hi, sir. This is Nazir. I'm from India.
Okay, Nasir. Yes.
Sir, I have recently graduated in B Pharmacy,
Okay.
passed out in 2025.
Okay, Nasir, you need to write this opera exam, but today we are talking about AMC exam for MBBS doctors. Okay.
Okay,
So,
okay,
Nasir, please wait. Our team will get back to you tomorrow.
okay,
Okay.
sir. Okay.
Okay. Thank you, Nasir. So, guys, if this is today's dedicatedly for medical doctors. So, if you have any questions, you can ask. And others also, our team will get back to you tomorrow. They will connect you individually. You can ask question whatever you have.
Hello, doctor. I'm Badrinath from Hyderabad.
Oh, yes, Dr. Badrinath.
See, like I have completed my MBBS. Like I would like to pursue my further education in Australia. So I got to know that like I'm looking out for options, just not Australia, but a little bit more interested in Australia. But I heard that we need to work for 2 years with our after our AMC two. In part
So,
two, we have
I mean,
to
you are
work for
not
two
working
years.
free
I
of
heard
cost.
it.
You are getting a job. So basically, in general, you need to pass AMC 1, then AMC 2 or AMC 1 plus WBA, and then you need to work 1 year, not 2 years. 2 years you need to work in UK.
Okay, for AMC, one year is enough, right?
Yes, after AMC 1, AMC 2, then 1 year you need to work minimum.
Come again. Can you please come again?
AMC 1 plus AMC 2, you need to pass both exams
Okay.
and then you need to work 1 year at least minimum.
Okay, 1 year at least.
Yes, minimum.
Why does it prolong? What is the issue?
I mean, no issue is that this is a government. I mean, in India, if you are doing MBBS, you need to work 1 year as an internship, right?
Yeah.
Same in Australia, you need to work as a RMO
No,
1 year.
1 year it's fine. 1 year is fine. Like at least 1 year. You use the word at least. So I
So
thought,
at least means if you are not getting any PG seat or you are not getting any other job, you need to continue the same job.
okay.
I mean, no one is going to, okay, just you, complete your 1 year and then you need to, you have no job. You can
Okay.
continue the same job and you need to try for PG.
Okay, basically we need to work for 1 year at least so that we will be applicable for applying for our further
Yes,
education.
yes. And simultaneously, you need to apply for PG or if you want to go for GP training. Okay.
Okay, like how many years is internal medicine over there?
Around 4 to 6 years only. Internal medicine around 5 years.
Internal
If you
medicine is
are
around 5
doing
years.
specialization, or generally 4 years will take basic.
Okay, like there is no particular time period for it.
Type period is there, 4 years minimum. But if you want to get super specialization, it may take 5 or 6 years.
Okay, with along with super specialization, it is around
Yes.
5 or 6 years.
Yes.
Can I get something like a PDF or something like which shares more about the post graduation?
This is not, you need to find out, So our job, we are a consultancy, right? Our job to help you to pass the exam, and we are guiding you this.
Okay.
Now this information not available anywhere.
Okay.
Yes.
Okay.
We will give you PDF regarding what services we provide each and every.
Okay, fine. At least can you share that?
Yes, our team will get back to you.
Okay. Thank you.
So guys, if you are in Hyderabad, you also can meet me on 11th. So I'm coming there. So Hotel Kinara Grand is there. Okay. And we have an office there basically.
Which Kinara again?
This is Amirpet.
Amirpet, okay.
Amirpet metro station is around maybe 200 meter or something, very nearby.
Okay, 11th of next month.
No, yes, 11th of May.
Okay.
Okay, so we can wrap up the session if no one has any query. And again, I'm requesting, if you have joined the session, please do leave with your name, mail ID, and mobile number with country code. My team will connect with you. So no more questions? Okay, so sir, can we wrap up?
Yes, Bharti, no more questions.
Okay, thank you everyone. Thank you, Dr. Akram and Dr. Rini for joining with us.
Thank you.
Thank you. Thank you everyone.
Thank you.
Thank you.
Bye. Bye.
Thank you,
Bye.
sir. Thank you. Thank you. Good luck to all of you.